Hi guys, Dr. Gillard here. This is the makeup lecture from last Wednesday where I only did 1 hour and I was supposed to do 2 hours. So this is for winter 2017 and here we go. I think here we go. There we go. Let's finish up last week. So we almost got through. We even ran a little short last week. So let's finish up last week's material. We were talking about melanoma. So primary versus metastatic melanoma. Remember, one of the things with melanoma, it likes to spread like crazy. It's not super duper aggressive, but boy, it sure likes to spread, and that's the problem with it. So primary stage generally presents, primary stage generally presents on the trunks of males and on the backs and lower legs of females. So that's the favorite place for it to show up. Now the metastatic stage, which we'll see is one of the end stages, we'll see those stages in a minute, it generally presents as small bumps or tumors inside the lymph nodes themselves. That's a bad sign. If tumor cells get into the blood after the lymph system, then it can metastasize to everywhere, particularly likes the liver and the lungs, likes the brain as well. Here's a nice picture of a malignant melanoma. Nasty looking. Here is the late stage of metastatic melanoma, and you can see here's an axilla or an armpit that's been shaved, and those are some seriously enlarged lymph nodes there. So some of the late stages is lymphadenopathy, which is swollen lymph nodes. It could be in the groin as well as the axilla, and an unexplained weight loss. Here's the 4 stages of melanoma. There's a primary stage where the lesion appears on the skin or under the toenail. Then you get, and that lesion is less than a centimeter. Then you get a secondary stage where the lesion gets bigger than a centimeter. And a tertiary or third stage is now the lymph nodes become swollen. So that means it's metastasized into the lymph nodes from the skin. And the 4th stage is now it's gotten loose from the lymph nodes, and it could be anywhere in the body. There's a little cartoon of what a nodular, there's different types of melanoma. I'm not going to go into all those, but this is a nodular type. And the take-home message here, this is the epidermis, right? Here's the basal layer, and notice it's way, way, way deep. It's in the subcutaneous layer or hypodermis. And all the blood vessels aren't shown, but remember this is filled with blood vessels down here. A couple more pictures of these things. Remember we talked about the ABCs on Wednesday, so you can't fold it. The danger signs are you can't fold it in half. It's variegated, meaning it's different shades, different colors here. It's got irregular borders, and it's bigger than 6 millimeters, bigger than the tip of a pencil, or the eraser of a pencil. So all of these, elevation is another bad one. These are all elevated. They're all variegated. You can't fold them in half, so they're asymmetric. And these are all melanoma. Here's a stage 3 metastatic melanoma that's gotten into this patient's lymph nodes. Not crazy big like the last one, but it's shaved and you can clearly see all the lymph nodes. In fact, this one's actually starting to get into the skin even. Cancer is growing right out of the lymph node and starting up here in the skin. And excuse me in advance, as you guys know, I'm still fighting this nasty Palmer bug. So what do you do? How do you manage these things? I mean, how do primary healthcare providers manage these? By simply referring them to the dermatologist ASAP. But you take a biopsy, you would perform that. The pathologist would look at it and write you a report on what he sees. If it is melanoma, then the lesion will be surgically removed, and it's a nasty, huge hole. Remember how deep these go. And furthermore, you want to take almost an inch, 2 centimeters around the periphery of the tumor, so it's a really significant size defect in the skin that's produced. And then finally, you want to biopsy or cut a piece of the sentinel lymph node out. And what's a sentinel lymph node? That is the lymph node that is the furthest downstream from the cluster of lymph nodes that is involved. And if it's downstream, you can tell if the cancer has spread downstream. If it's spread downstream, the chances are it's spread to other parts of the body. Sebaceous glands and sebaceous cysts. Oh, I don't know if we even got into sebaceous cysts, but very common type of cyst. Anyway, recall there are two types of exocrine oil secreting glands. There's a hair follicle stimulating, and then there's the stinky one, the independent or free. So we're going to concentrate on the regular run-of-the-mill hair follicle types. It's a cartoon of it. There it is right there. Remember, it is part of the pilosebaceous unit, most prevalent, and it's formed or it's part of the hair follicle, rector pilae muscle, so it's all part of this unit here. And what does it do? It secretes a oily, waxy stuff that we all know. If it's at the end of the day, you can just rub over your forehead if you're young enough, and you'll feel this stuff, and it's called sebum. And this what lubricates and waterproofs the skin and hair. It's found everywhere in the body except the globular skin, especially these glands are particularly prevalent on the forehead. It's made up of wax esters, cholesterol, triglycerides, squalene. So really waxy, greasy type stuff. Here's an electron microscope, scopic view of it, and you can see it here, how the hair's been growing and it's actually coming right out. But that's it. Bacteria love that stuff, by the way. Sebaceous glands, surprisingly, are not only present at birth, but they are very active at birth, and they secrete high amounts of sebum. And sebum production usually starts declining around 3 or 4 months of age, if not further. Certainly by 1 year, the production has tapered way down. And we'll see there's a couple of types of acne that neonates and infants can get. We'll talk about that, and that's because of this high production. And during puberty, of course, because of the androgens that come on, the sebum production is quite high, and acne can run wild at that time. Sebum glands have receptors for testosterone, specifically for dihydroxytestosterone, or this DHT right here. And when DHT is floating around the serum and binds to these receptors on the sebaceous glands, they are stimulated to crank out more sebum. Sebum volumes do not completely decline after menopause. After puberty they slow down when you get around 20 or so, but they don't really fall off in females until after menopause. And in males, by the 50s or by the 6th, the 7th decade of life, they fall way off. So you can still have some trouble with acne for a long, long time. The sebum also has some antibacterial and antifungal properties, and it is the pathological problem with acne vulgaris. Acne vulgaris is a direct result of sebum production. Therefore, you could say that sebum is comedogenic, meaning it causes acne. What's a vulgaris again? Acne vulgaris is the most common form of acne. We're not going to get super deep into acne, but there's nodulars, different types of. I think I mentioned them actually before. The volume of sebum varies between race and between individuals. Some people produce a lot of it, some people don't. Typically, on average, sebocytes produce a steady flow of sebum at about 1 milligram for every 10 centimeters squared of skin within 3 hours. Don't expect you to know that number, but people do keep track of this stuff. And a lower than normal production of sebum is called sebostasis. And sebostasis is definitely associated with xerosis, which we just talked about. That's dry skin. In fact, some people use sebostasis as an AKA for xerosis, but that's really, I don't think that's really correct. And it's almost always present in patients with eczema, and the next phase of eczema is ectopic dermatitis. Greater than normal production of sebum results in a condition called seborrhea. So if you have too much sebum production, then you have a condition called seborrhea. And this is definitely associated with acne or acne vulgaris. Abnormalities. So in general, acne patients, if you biopsy their skin, they have a larger, the sebaceous glands are bigger, so they have larger in size sebaceous glands, and they have, those glands therefore produce a higher volume of sebum when compared to normal people. And again, sebaceous glands are slaves because of those receptors to the magnitude of DHT in the blood serum in both men and women. So increased DHT equals increased sebum production. Men, that's usually testosterone production. Women from androstenedione production. We don't need to get into that. Hopefully you would get into that in endocrinology. With regard to the occurrence of acne, however, even though sebum levels are usually associated with it, it's not, we still don't quite understand the entire story. Because some people, for example, with Parkinson's disease, they have very, very low productions of sebum. In fact, they have seborrhea, which is super low, or I'm sorry, super high. Sorry, exact opposite. Patients with Parkinson's disease have very high production levels of sebum, so they have seborrhea, yet they don't get acne, which is very strange. So there are other factors involved in acne that we don't understand. Some research has demonstrated that increased anxiety or anger can also cause outbreaks of acne. And again, we don't know why. We don't understand the whole story yet. So acne vulgaris is a condition involving the pilosebaceous unit. Typically occurs in individuals that are pre-exposed, especially in regions where sebum production is high, like the face, the forehead, upper part of the chest and back, behind the ears. There are several forms of acne, or the more severe forms of acne, like the nodule cystic acne. I think we talked about that. But those are seen more often in males than females. But the acne in general is more persistent and hangs around longer in females. Especially around menstruation, it seems to pop out. What is the cause of acne? Again, we don't know the whole story, but in general occurs when the normal pilosebaceous unit flora, and so those are anaerobic bugs, right? They live underneath in the dermis of the skin. The same one that there's the theory on disc herniation, chronic back pain, modic change, which we'll talk about in 8th quarter, one called P. acnes, proprio, I don't even want to say it, bacterium, Proprion bacterium acnes, or P. acnes. Everybody calls it P. acnes. That is a particularly pesky bug. We'll talk a lot about that in 8th quarter. But anyway, the bacteria loves sebum. It's like special food for them, filet mignon for them, and so they gobble that stuff up. Therefore, if you get increased levels of sebum production, you get an increased population of P. acnes, and it ends up clogging up the hair follicle, or the shaft or the hair follicle itself gets clogged up. And when the hair follicle gets clogged, those clogs are called comedones. Comedones. Or comedones, some people say. Tomato, tomato. There are two major divisions of acne. There's non-inflammatory acne, which only consists, oh, there's a star, so make sure you know this, high yield stuff. Non-inflammatory acne is only if you have opened or closed comedones, which we'll learn is black and white, blackheads or whiteheads. We'll learn more about those. Now, inflammatory acne, that's when you get a real pustule, a nodule, a papule. So if you don't see those, if you just have blackheads and whiteheads, you have non-inflammatory acne. If you have the real deal, those erythemic papules, pustules, and nodules, you got inflammatory acne. The nodules, they may be pus performing, they may have blood in them, and sometimes the nodules can become filled with, or they can become filled with this extra epithelial tissue, which can't go away, so they can leave scars, in other words. Nodular cystic acne is the kind that scars. I'm pretty sure we talked about that before. Here's some lesion types. So here's the basic white heads called closed comedones, the basic black heads, which are called open comedones, with one little white head mixed in here. Now, inflammatory lesions they're more erythemic. You can see pus in these, papules or pustules. There's just fluid in these. And now these have actually laid down tissue inside of them and have become nodular. And these can extend into the dermis and cause scarring. Inflammatory acne classifications. So this is classified as mild. There's no nodules in mild acne. Moderate acne, you'll have some nodules. And severe acne, you'll have these big, some people call them boils, but they're nodules. And these are the kind that do leave scars. And there's just a little cartoon of a normal hair follicle, and there's the sebaceous gland dumping the normal amounts of sebum, which you can't really even see. Maybe it's that red stuff there. And then a closed comedone, or this would be called, sometimes you can call them just comedo, closed comedo or comedone. This is a white head, and we'll see what this stuff is in a minute. And there's a black head there, open comedone. Make sure you know what an open comedone versus a closed comedone is. So let's talk about the comedones. They are dilated, epithelial-lined follicle sacs that are filled with laminated keratinous material, could be lipid material, and even live bacteria are mixed in there. And again, there's two prominent forms of this in Acne vulgaris: open comedones and closed comedones. Open comedones are blackheads. Okay, make sure you know that. Also know they're non-inflammatory. Really easy to write a question on this. They are capped with a plug made in the stratum corneum plug. It's an earlier stage of acne vulgaris. In fact, it's the earliest stage. And that black stuff is not dirt like your mom's probably told you. Oh, you didn't scrub hard enough. You got dirt in your pores. It has nothing to do with dirt. That is melanin that has become oxidized. So it's oxidized melanin, not dirt. And these typically won't. They can, but they typically don't progress into an inflammatory type lesion. Classic open comedos or comedones. Closed comedones. So those are the classic whiteheads. They are small white papules without any scarring or erythemic change, so there's no redness around them. They're just white dots. Now these are precursors to acne vulgaris, and they commonly go to the next phase, which would become inflammatory, and you'd get an erythema, which means you get red around there, you get inflammatory cells, you get pus in there. So these are the precursors to the real acne. But they're still, just because they're precursors, they're still classified as non-inflammatory acne. They don't always have to turn. Maybe if you clean them real hard or take antibiotics, you could stop them from turning into real acne. Kind of hard to find a picture of these, but you can see some right there. Okay, so neonatal, those are brand new, spanking new born babies, and we've seen these on a couple of our grandkids and on our kids, so it's very, very common. So very commonly seen in almost a quarter of newborns, 20% to be exact, will have neonatal acne. And lesion typically appears within the first couple weeks of life, 2 to 3 weeks of life. There's a classic picture of it. It looks just like acne, a little pustules there, or it looks like chickenpox. So it can look like other things. Lesions are best described as small, inflammatory, erythemic, so it's real inflammatory acne, papules and pustules, just like acne. Typically occurs over the cheeks, may also occur in the forehead, chin, eyelids, scalp, neck, back, chest, and we're past the non-inflammatory stage. We skipped that. So open comedones or comedones are just not seen, or open comedones, blackheads, are not seen, and it doesn't typically turn into the severe nodulocystic type of acne. So nodules are also rare. Diagnosis, you don't have to do histological evaluation to know your kid's got, or your newborn's got, infantile acne. It's just diagnosis is made by their appearance. Histologically, the pustules, this is kind of interesting, would reveal neutrophils, so as expected, part of the inflammatory, the bean reaction, basophils, eosinophils, neutrophils. And here's the kind of wild card here. Spores, yeast spores tend to show up if you do get these biopsied. So that's a little strange. So there's a newborn with papules and pustules, no comedones, so your run-of-the-mill neonatal acne. What's the cause? We don't quite understand the cause of it. Well, there is some increased levels of estrogen, but they usually don't start yet. Usually ramps up a little bit later. But the yeast flora thing is interesting. So one of the theories is, although it's controversial, is that yeast has gotten in there somehow and it's physically clogging the hair follicle, and then sebum can't get out and bacteria go to town, P. acnes multiply and multiply and multiply, and that causes it. So some of the treatment is actually targeted for yeast. It's not driven by testosterone like infantile acne is, because it takes a couple months for testosterone levels to start rising in a newborn. Differential diagnosis. This one can be confusing because it does look like seborrheic dermatitis, early atopic dermatitis, eczema, miliaria. So there are many differential diagnoses. What do you do about it? Treatment, you don't even need to really treat it. The condition usually peters out by the 4th month. So if it's severe or if it hangs around a little longer, you could start using a low potency topical corticosteroid like hydrocortisone 1% solution. The imidazoles like clotrimazole could be used as well. and it's effective for the yeast component of it. So what's this? Oh, imidazole. It's just that's how I pronounce things for you. That's my pronunciation guide. Im like Jim, like egg, imidazole. We'll see those a little later too. For another acne-like condition. Prognosis, again, it's usually no big deal. They're self-limiting usually. By 4 months they should be gone. Why? Because the DHT sebum production generally decreases by then. I'm not sure if that one is actually true, because DHT, I don't think we know why. I think I'm going to take that out of there, so disregard that, because the DHT usually starts ramping up, and by 4 months it's probably higher. So this is not, I don't know where I got that one from, but let's take that one out. All right, so if it doesn't go away, and now the neonate is 4 months old, now they're said to have infantile acne vulgaris. So it's not nearly as common as neonatal. Boys tend to be affected more than girls, much less common. Again, the onset is 4 months, might show up, the range is 4 to 16 months, but it typically occurs after the onset of neonatal acne, so the kid will almost always have neonatal acne before this, but he must be at least 4 months old to be diagnosed with infantile acne vulgaris. Now this one, there is a strong familial tendency. 25 to 50% of the patients have a positive family history for severe acne, so their mom or dad has battled acne, and a lot of these I don't know if they're children yet, these infants, and 25% of them have actually a history for the mom or dad or a sibling will have battled infantile acne themselves. So there's definitely a genetic link to it, and it's characterized again by the presence of real acne lesions, which occur primarily in the cheeks. Now this time you get the whole spectrum. You can have a mixture. It could start off as open and closed comedones, so you can have a non-inflammatory acne, and that can progress into an inflammatory acne, which contains papules, pustules. Now this one, you can get even real nodules, so this is like the real deal. It's like the type that you get in adolescence. And again, open comedones are blackheads, closed are whiteheads. Nodule formation is scary because you can actually start getting scarring, which will be with you for your life. The nodules will get down into the dermis, and that'll leave a scar. So you got to take this one really seriously, unlike the neonatal acne. Not completely understood the pathogenicity or what causes it. Again, we're not completely sure about it. One theory says it's secondary to abnormal increase in the production of adrenaline, or I'm sorry, of adrenal and gonadal androgens. So remember, I won't get into that endocrinology bit, but if DHT levels could rise at this time, it could be responsible. Actually, you know what? That part I took out is actually right, because I think the DHT levels are present at birth, and then they do normally fade out by 4 months. So I think that was actually correct. I'll just stay away from that on the test, though. And so increased levels of luteinizing hormone, FSH, dihydroepiandrosterone from the adrenal gland. Bottom line, causes the increase of testosterone production. Testosterones are sometimes that of an adolescent. Now remember, that's not normal, right? The testosterone is supposed to fall off by then. And because of DHEA's influence, the more acne causing testosterone is elevated. So elevated testosterone is one of the theories. Increased testosterone then stimulates sebaceous glands to ramp up sebum production proportionally. If you ramp up the sebum production, you're going to feed the P. acnes, and you're going to get clogging of those ducts, and you're going to get acne. Differential diagnosis: cutaneous infection, seborrheic dermatitis, underlying hormonal problems, even rarely, in CVP path we talked about, adrenocortical tumors could do this as well. That's pretty rare though. There's a condition of some actually nodules there, right? Even some previous scars on this unlucky little guy. What's the prognosis? It's usually good. Normally by the age of 12 months, the androgens have finally went away and the acne goes away. So that's the usual production if you're unlucky enough to get this. And the acne goes away because of decreased testosterone production and therefore decreased sebum production. Therefore, P. acnes population is not as high. On occasions, though, this can become a permanent problem in some unlucky infants. For the workup, so if the acne is really bad or persists beyond that 12-month mark, there's a star by this one, then you should order a complete hormonal evaluation and refer to an endocrinologist because something is amiss. What do you do for treatment? Now, unlike neonatal acne, where we're not really that concerned about it, you got to jump on this one right away. Even mild cases of infantile acne can cause scarring, right? And you can have nodules form. So, in fact, up to 50% of those affected end up with permanent pitting and scars on their cheeks from this. So, you need to get on this. This is nothing to mess around with. You can use retinoid. The retinoids again is a good form of treatment. I mean, the dermatologist would prescribe this. Now, this unfortunate person, these are acne scars from when she was an infant. They followed her all the way into. I mean, once the scar's there, it's there for life. So, what's the more treatment stuff? You can use alcohol or avoid alcohol-based washes and gels because it can get into their eyes and burn them. You can use, for those severely affected, antibiotics like erythromycin. They've been around forever, so you can help try to eliminate that bug population. This poor little guy has got it really bad, but it looks like a real bad case of teenage acne. And that's what it is. It's real acne. Probably had elevated testosterone levels for some reason. All right, switching gears. Now we have keratosis pilaris. Keratosis pilaris. You're going, what the heck is that? Keratosis pilaris. We've all had this, or not, maybe not all of us, but this is very, very common. So it's really easy to confuse with a infantile acne or childhood acne or even teenage acne or just acne in general. It's a non-inflammatory skin condition, very common in people with atopy or who have atopic dermatitis, characterized by the appearance of small, rough papules or even pustules, but you typically don't get any nodules. So just like acne vulgaris, like a mild acne vulgaris. Histologically, the lesions consist of hyperkeratotic follicle papules. So they're just, the papules are filled with keratin. More common in children with peak age in adolescence. More common in children with peak age adolescence. What does that mean? Oh, I see. So it's more, geez. It's more common with kids, adolescent kids. And but it may occur at any. Hey, one of my daughters has trouble with this. And here they are. It's the back side of the tricep here. It's just these little bumps. It kind of looks like acne, but it's kind of not. They're just these annoying little bumps. It loves the posterior lateral surfaces of the arm, and you see this all the time on the anterior surfaces of the thigh. It loves those two regions. It's not dangerous at all. There may be some psychosocial issues. You may not want to wear your bikini if you have that stuff on, and you can imagine the teenage problems with this stuff, but it's definitely not dangerous. It's not going to leave scars. Lesions on the face, definitely confused with acne. But here's how you differentiate KP from acne vulgaris. So KP findings, keratosis pilaris, these lesions will be very uniform and they are usually very small. Acne can be all over the map. You can have big ones, you can have small ones, you can have pussy ones. These are uniform and small, and the key is often that they are superimposed, or they live on top of a skin that is very red, dry, chapped, cracked. So perfect example is right here. So keratosis pilaris of this child, you can see the lesions. You can see the little dots here. See all the little white things? They're all about the same. Maybe there's a couple that are a little bigger, but in general they're the same size. And the key is, look at the skin. It's erythemic like crazy. It actually looks a little raised and chapped and xerotic. What does that mean, xerotic? Dry, xerosis. There's another one. All the same size lesions. But remember, typically though, they're on the back of your arms, front of your thighs. Here's a classic example. Here's one on the back. Okay, what do you do about these? First line is emollient therapy. Say that 3 times fast. Emollient therapy. That's just gels, lotions, anything to kind of calm down that crusty red skin. And then you can use retinoids again. It's actually very effective for using this. Here's some Retin A, which is it's prescription still, which is tretinoid. It does a good job. The only trouble is there's some good things and bad things about retinoids. I'm not going to go crazy into it, but they do, and some people actually irritate the skin quite a bit and turn it red, and in some unfortunate people it can make the condition worse. Usually it clears it right up, but when you're using it, you're really sensitive to the sun. So you have to be careful with wear sunblock, which could worsen the acne, but you have to wear sunblock. Okay. Short course, we're still under treatment. The next big gun, you can do a short course of topical steroids, which can definitely calm down the redness. This is a trick used if you have this problem on your face, you need to do a big public speaking event. You can use this topical steroid, but you can't use it all the time because it can start to damage the skin, roughen up the skin, which is not good. The roughness of this condition can be reduced by using an aspirin-based lotion, salicylic acid lotion, urea cream, or ammonia. So any strong acid or base creams can help kind of take that roughness off. And abrasive washing techniques don't work anymore. They used to say use some sand or just scrape all that roughness right off. That does not work, so don't. That's kind of old school. It's really old school. So here's on the gluteal musculature, over the buttocks, you can see all very uniform looking lesions here. If you rub your hand over that, it'd be just like sandpaper. Okay, switching gears. Melasma, I think we've talked a little about this before. The mask of pregnancy. It's a common acquired light, dark brown hyperpigmentation disorder of the face, so it's going to darken. You're going to have too much melanin. Hyperpigmentation disorder. And it's definitely genetically related. Kids will typically have this if their parents have had it. Can be a huge psychosocial issues, we'll see in a minute. Probably not as bad as its counterpart though, the hypopigmentation disorder, but we'll get to that. So psychosocial issues can be caused by proliferation or is caused by a proliferation of melanocytes in the stratum basale. Too many melanocytes producing too much melanin in patchy areas. Typical melasma loves to happen when people get pregnant. So this is the color of this person's skin normally, and you can see this huge dark melasmic spot. We'll see a bunch of examples, but it loves the face. Under the lips is real common. It's from an increase again in melanin production, usually on the face, the third most common pigmentary disorder on the planet. Hispanics are particularly susceptible to this for whatever reason. Black people and Asian people can also get it, but not as much as Hispanics. Pigmentation develops slowly. It's not a quick onset like one we're going to talk about in a minute, but there are no signs of inflammation. Associations with this, very common during pregnancy and typically will fade away after delivery. If someone's on contraceptive hormones, this will definitely aggravate it if there's any predisposition for it. Thyroid deficiencies or dysfunction, both hyper and hypo, can cause it. Certain medications like anticonvulsants can do it. And the weird thing about melasma, this is a female disease for the most part. 90% of the people affected by melasma are female. A little star by that one. It's a typical one. There's some open comedones too. See the little blackheads on the nose, open comedones. But that's not what this is what we're focusing on. Got a big scar right there too. Anyway, you can see the hyperpigmentation disorder. Again, the etiology, we don't completely understand why it happens. There's usually a history of a lot of sun exposure. Genetic factors we talked about already are definitely there. These are the most important risk factors. If your parents have it and you have been exposed to the sun, you probably will get it as well. Can be self-limiting, but so it can wax and wane, but typically once you have it, you're kind of in the club. It can come and go. Very, very difficult to treat. Treatments are hypopigmentation aid or hypo, so you can try to take some of that excessive pigment out with chemical peels and laser therapies. Cosmetics are typically have to be used, though they're not super effective. Definitely want to avoid the sun, and if your parents have this and you're a kid, you're going out in the sun, make sure you use a sunscreen, a good one that has both UVA and UVB block in it to prevent these from occurring. Now on the opposite side, we can have hypopigmentation disorders, and the key one is vitiligo. So vitiligo. It's a Greek word. It means calf's white patches. And it's an acquired disorder of hypopigmentation characterized by not an increased number of melanocytes, but now we have a decreased number of melanocytes in specific regions. Huge genetic population, or they're good genetic predisposition, family history in about 30, there's a history of a parent or some immediate family member who has this in 30% of the cases. And it affects all races equally, so this is not a Hispanic thing or a black thing. Genetic predisposition, yes, we talked about. There's two types. There's vitiligo A and vitiligo B. We'll talk just about vitiligo A, which is by far the most common. Usually presents as a symmetrical, almost a strange, weird symmetrical hypopigmentation of the skin, as we'll see. You have it on one side of the body, it's almost in the same spot in the other typically. It affects 1% of the world population, typically arises following a trauma, so things that can, if you're predisposed for it, things that can set it off is trauma to the area. That darn sun again, if you get a sunburn, if you get sick, if you are probably like you are stressing over finals and boards right now, can bring it out. quite common around the mouth, armpits, axilla, axillae for plural, eyes, gluteal creases, so in your butt and around your butt crack, and the anterior parts of the knees. And but it can be anywhere. Here's some typical high-risk areas around the eyes, mouth, armpits, kind of the crotch area, the butt area, and on the front of the knees, for not on the back, but on the front. So kind of weird. Classic stuff here. So no pigment here, right? No pigment. That's just unpigmented skin in this dark-skinned person. There's another one. Look at how symmetrical this is. You can almost fold it in half. So very, very strange. And you can see it all over her body here. Vitiligo. What the heck causes it? Again, we still don't know for sure. It's believed the biggest one is some type of autoimmune reaction where for whatever reason the melanocytes get destroyed by, they get tagged with some antigen and the body attacks them, no longer recognizes them as self, and attacks and destroys melanocytes in specific regions. But why is it symmetrical is the strange thing to me. Neurological signaling, there's a theory on that, where somehow melanocytes are just turning themselves off, some probably genetic defect. But again, how come it's not over the entire body? Why is it isolated to the same sides of the body? Then there's a toxic autodestruction theory where the melanocytes kill themselves secondary to a release of toxins within them. And here's a white person. Although I guess she's kind of dark-skinned, but she's got it, and probably look like this on the other side of her face too. Classic vitiligo. And again, it's not dangerous. No symptoms with this at all. Here's the classic knee, front of the knees here. But as you could, I mean, major psychosocial problems, right? There are some differential diagnoses. The biggest one is pilaris alba. These pithoric lesions can look similar, but notice this is not a complete loss of skin pigment, so that would be the difference. If this was complete loss, this would be pure white. There's a bunch more of these. And the course and prognosis, typical course 80%, our typical course is a rapid onset. So in 80% of people, this comes on really, really fast. And it's followed by a slow progression over the years. So it comes on really strong and just like a shock, and then it slowly gets worse after that. You can spontaneously repigment about a third of the people, 30% to be specific, but 30% of the people will have pigmentation, repigmentation, where it may come close to going away, or maybe it goes away, but unfortunately this is another one of these where once you're in the club, you're probably in the cub, because it'll come back. And again, psychosocial problems, especially people of color, right? When they, maybe white people not as bad because they're already kind of white, but people of color, it's very contrasting. And remember, there's no predilection for race. It affects all races equally. It can even happen in the hair sometimes, not in the eyes though. Like the back of the hands. There's another one. Can even get on the top of the penis. What do you do for treatment? So the first line of defense is topical corticosteroids in combination with topical D3. Seems to work pretty good, but not the greatest. The second line of defense is some types of phototherapy, like this MBUVB. Phototherapy is the best one, in addition to some other topical calcineurin inhibitors. And the repigmentation rates are between 40 and 100%, so decent chance of helping. The complete repigmentation rate on the face is about 70%, so this is probably the best chance here, this MBUVB phototherapy with the other inhibitor applied topically. Third line of defense, if that doesn't work, you can try laser therapy with combinations of the above stuff. Here is a patient who is repigmented after, I don't think her therapy is complete, but to give you an idea how it's repigmenting the areas of pigmentation loss. This was with phototherapy with narrow band UVB therapy. And here's a PUVA therapy success here, although it's significantly lightened all of her skin, but it looks a lot better than this perhaps. Okay, switching gears again, we're almost done. Acrochordon. Acrochordon. You're going, what in the heck? You probably never heard that word in your life, acrochordon. But you have heard its AKA. These are the pesky and very common skin tags. So acrochordon skin tags, very common. About 1/4% of the population have these. A couple daughters have this. Very super common problem. The key is to differentiate them from polyps. So acrochordon or skin tags, they have a stalk, but the tip of the lesion or tumor, the tip of the tumor is round. So it has to be round in order to be a skin tag. If it's flat, if it looks like somebody smashed it and it's completely flat, then you have a polyp. You don't have a skin tag anymore. The cause of these, don't know what causes these tumors. Big genetic connection between them though. They're described officially as a soft skin color or darkened, pigmented means darkening, pedunculated papule. People who are obese, and especially obese females, have these more than normal people. They love to hit the axilla, around the axilla. The neck, axilla is 48%, neck is 30%. They can hit the groin, they can hit around the eyes as well. Here's some around the eyes. And here's some around the axilla. That's quite a few of them there. Typically starts in the 2nd decade of life, so they can start in the childhood or adolescence. And they can increase in frequency up to the 5th decade of life. Not strongly associated with colonic polyps, which can be cancerous, right? We used to think that they were highly associated. In fact, we'd recommend a colostomy because of these, but you don't have to do that. The research is pretty strong on that. They're not related to polyps. And let's see, they are classified as a tumor. They can grow up to 1 centimeter in size and still be called an acrochordon. And the stalk can become quite long and narrow. But again, the presence of a long stalk with a flat tip, like somebody pinched it flat, that reclassifies them into a skin polyp. Easy to remove them. You can just, the doctor can cut these things off. I've had a daughter tie a hair around it and knock one off like that. So they're really easy to get rid of. But go to the dermatologist to do this though, so don't get infected. Excuse me. Local anesthetic is not typically needed, and it's not uncommon for them to twist and kind of self-amputate, or auto-amputation can definitely happen. Here's some more of them in the axilla. Now skin polyps is almost the same, but they're typically a little longer. The stalk might be a little narrower, but the head again is flat, has a flat head. So that flat head or flat tip differentiates them from a skin tag or acrochordon. Histologically speaking though, you have to be a little bit careful of these things. Usually they're no big deal, they're benign. But every now and then they can be malignant. So malignant melanoma can occasionally disguise itself as one of these skin polyps. Or if you do a histological review, or sample of one, it looks just like a skin polyp. It's got a flat head, and lo and behold, it's nothing more than a skin tag, or even a mole, a nevi, or that would be nevus singular. And it's not uncommon to have skin tags or acrochordon mixed in with skin polyps. Favorite target of polyps is the eyelids, groin, and axilla. They don't like the glabrous skin, which is the palms and the soles of the feet. Here's some nice looking skin polyps. See how flat the tops are? It's the best picture I could find of these things. Sometimes the polyp can become twisted, we talked about that, and they self-amputate, but they can look really scary while they're dying. And it's not cancer or anything like that, it's just a kind of a self-strangulated skin polyp. This black has like a black head. It's from ischemia and death of the tissue. So the blood supply goes through the tiny stalk, and if it gets twisted, it can cut off the blood supply and the head will die. And they can look quite weird and scary looking. But this is just such a skin polyp where it's twisted on itself and it's cut off its blood supply, and that's called an infarcted skin polyp. Hey, we reached the end. Okay, so test will be next Wednesday at our regular time. It'll be the same format. You'll have 10 slide questions. Name that lesion, and then you'll have 10 multiple choice questions. And we will see you next Wednesday. Bye-bye.